Well, thank you, everybody, and thank you for inviting me to be here today. It's a privilege, and it's been really great to drive down here and see the city. So hopefully we'll give you some thought-provoking things that have occurred recently in pain management. We'll see. I don't have any financial relationships to disclose. And just wanted to start out talking about chronic pain and the prevalence and kind of impact of chronic pain. And these sorts of statistics have been published multiple times, that about 50% of Americans have what they would describe as chronic pain, and the majority of those would call that moderate to severe. The impact of that is actually huge, and it's hard to think about these numbers, but the most recent numbers from 2020 were that we spent about $130 billion in direct medical costs for chronic pain care, and there's probably about the equivalent in terms of time loss and loss of productivity in society. So it's a big problem and has a huge impact on people. This is a sort of classic description of the different types of pain, divided into nociceptive pain, which might be further divided into visceral pain, organ pain, and then more somatic pain like musculoskeletal pain, as opposed to neuropathic pain, which can come from either the central or the peripheral nervous system. And I'll talk a little bit more about these kinds of pain, and then also what we're recognizing as something that we've all seen before, but that everything doesn't necessarily fit neatly into these two categories. These pictures are on the left, a Pacinian corpuscle, which is actually a mechanicoreceptor, but it's just so elegant the way that this is designed with this almost spring-like thing that then can trigger that nerve, which is a myelinated nerve, to function. And normally this is just a receptor that feels mechanical pain, but with sensitization, stimulation of these peripheral receptors can become painful. The nervous system can become sensitized to a degree that these become painful. But most peripheral nociceptors are actually free nerve endings that respond to either thermal or chemical or intense mechanical stimulation. And they're unmyelinated nerves that are free-floating in the skin in particular. And then on the right is this kind of classic Cartesian description of pain. There's a stimulus in the periphery, and then that's registered in the brain, almost like a bell is ringing in the brain. And we now know that pain reception and modulation is much more complicated than that. This is just a graph from around 1998 from Dr. Bennett describing the types of neuropathic pain and their prevalence. And most common neuropathic pain is neuropathy pain. Diabetic neuropathy, but also other kinds of neuropathy. And then post-herpetic neuralgia is actually quite prevalent. In the central nervous system, such as with spinal cord injury or post-stroke pain, it seems like the spontaneous generation of pain in the nervous system is one mechanism, but also the synthesis of different modalities of sensation coming in and not being adequately synthesized, that often creates pain. So deafferentation pain in the spinal cord, for example, seems to be of this sort. There are not necessarily painful stimuli coming in, but the way that they are put together and then interpreted in the brain is of pain. And so all of these mechanisms are quite different, and this division between nociceptive and neuropathic pain has been useful in trying to decide how to treat these things, because there are different drugs that seem to have differential effects on those kinds of pain. But more recently, people have begun to recognize this type of pain called nociplastic pain. So the nervous system actually changes in a plastic way after chronic pain has been present for long enough so that there is spontaneous generation of pain, or stimuli that weren't painful before are now painful. And historically this was called central sensitization pain, and that's still relatively accurate. But with this new taxonomy, I think it's going to open the door for people to study the mechanisms of this type of pain. And the typical, or maybe prototypical type of nociplastic pain would be something like fibromyalgia. There's not actually tissue damage occurring, there's not a lesion of the nervous system, but yet people developed hypersensitivity to touch and spontaneous pain that resides within the nervous system. And this is a publication from a couple of years ago by the International Association for the Study of Pain that sort of describes how we would define nociceptive pain. So it's a pain that's not purely nociceptive, it's not purely neuropathic, it's been ongoing for at least 3 months, and it's associated with some of these other features like sensitivity to touch, allodynia, and often the kinds of things that we see in these conditions that might include irritable bowel syndrome or fibromyalgia, again, as the prototype, including fatigue and cognitive dysfunction. And so this is physiologically real. I think early in my career, I might have interpreted this as just poor pain coping or somebody who, for whatever reason, has a psychological amplifier of pain. But as we study this further, we're realizing that it relates to abnormalities in the spinal cord and then ways that the central nervous system talks to itself. So the way that the limbic system talks to the primary sensory cortex, for example. And those things change over time in a way that creates nociceptive pain, but can also be reversed through some approaches that we can talk about later. So just a reminder that kind of a prototype of nociceptive pain would be something like fracture or arthritis. The neuropathic pain often divided into central and peripheral neuropathic pain, and then nociceptive pain, nociplastic pain rather, this new category. So I'm going to use osteoarthritis to talk about one of the main topics of today's talk, which is the use of non-steroidal medications in pain. The radiographs on the right are describing the Kellgren-Lawrence scale, which you might see frequently in descriptions of radiographs, just how we describe how severe is arthritis. Most of the guidelines around treating arthritic pain have talked about these drug therapies. Acetaminophen has been in again, out again. Does it work? Does it not work? Clearly, it's got some safety benefits in terms of nonsteroidals, but both in osteoarthritis and in low back pain, the most recent studies have said that acetaminophen really does not have a significant analgesic benefit. I have patients who use it and they find great benefit from it, and that's great, but in larger populations that hasn't been borne out very well. The nonsteroidals we'll talk about in a little bit more detail here, but their benefit is not as big as we think it is. And in arthritis, the benefit is equally significant as just regular exercise. Topical nonsteroidals are really a great thing to do if you've got a single, especially small joint, and they can also be injected. And I've seen many papers recently, especially with Toradol being injected into joints as an efficacious delivery method for nonsteroidals. And then, of course, oral nonsteroidals, that's the main route of use. Duloxetine is also effective, and we'll talk more about that medication in a bit. And then intra-articular therapies. Historically, we've used a lot of steroid injections in joints. It turns out that while they do give short-lived relief, repeated steroid injections into joints seems to accelerate arthritis, and so we're looking for different agents to use. The current rave is PRP injection, which does have some benefit, proven benefit in at least arthritis of the hip and knee. And we're looking at other kinds of agents to put into the joint. In fact, historically, opioid injection into the joint has been useful, and again, nonsteroidal into the joint can be useful and probably does not accelerate arthritis in the way that steroids do. So this is a slide put together by one of our pharmacists just talking about the general mechanism of action, which is to interrupt various cascades of the arachidonic acid cascade through primarily inhibition of the cyclooxygenase pathways that create inflammatory substances. The adverse effects I think we're all quite familiar with, and I'll talk about in more detail. When you're thinking about what nonsteroidal agent to use, the two major considerations are duration of action and Cox specificity. And so we've seen evolution of these drugs over time, and I'm going to talk about that in a little bit more detail. But the constitutive enzyme of Cox that's always present is COX-1, and then COX-2 is thought to be elaborated during times of inflammation. And so there's been a lot of thought about, can we use COX-2 specific agents to protect the gut and other constitutive functions of cyclooxygenase while still helping with pain? So this is kind of a nice slide. You can find your favorite nonsteroidal on this chart and see where it falls in terms of its relative COX-1 and COX-2 specificity. The first nonsteroidal that we had in the United States was ibuprofen. And I learned today that ibuprofen was actually named after its chemical makeup. So it's isobutyl propionic acid derivative, which has a phenyl group on it. So it's ibuprofen. That came out in 1961 and was released in the United States in the 1970s. It was thought to be a safer alternative to aspirin, which was known to cause a lot of GI bleeding in particular, tinnitus, and so scientists were looking for more selective nonsteroidals. And as this drug came out, the relative contributions of the different cyclooxygenase enzymes were elicited. And then in the late 1980s, early 1990s, if you remember, Vioxx came out, and Vioxx is a very COX-2 specific agent, but it was discovered it was causing cardiovascular issues and stroke, and so it was removed from the market, I think in 2001. And the most COX-2 selective agent that we have now is Celebrex. So in general, the COX-2 agents, as you know, are going to be more easy on the stomach and not interrupting those constitutive functions of cyclooxygenase. Those COX-1 inhibitors tend to be harder on the stomach, perhaps a little bit less dangerous in terms of cardiac and stroke risk, but not clearly so, and I'll show you some more detail about that. The one that I use most commonly currently is meloxicam, which is fairly COX-2 specific. It's about $30 per month as opposed to Celebrex or celecoxib, which is quite a bit more expensive. And then this is, I think, a useful thing to look at. In repeated studies, naproxen has been described as the lowest risk from a cardiovascular perspective. So your patients who've had, some element of, coronary artery disease or carotid disease, if you're going to use a nonsteroidal, at least in studies that we've seen to date, naproxen is probably the safest, although 2 years ago there was a much larger study of 24,000 patients, and that relative advantage of naproxen did not emerge and didn't look any safer in those areas than the other nonsteroidals that we use. But these are the most commonly used ones. I think it's important to know that the side effects here are dose dependent, and there tends to be a ceiling effect with all nonsteroidals. So using the lowest possible dose, lowest effective dose is important and will reduce risk of side effects. Diclofenac was one that I used to use quite a bit, and I found it was pretty effective with my patients, but it has a unique problem with liver toxicity. And so in learning that, I really stopped using diclofenac very commonly. And it's got a big cardiovascular risk apparently at doses of 100 milligrams or more, and the typical dose for diclofenac is 75 milligrams twice a day. Celebrex, again, is thought to be, because of its COX-2 specificity, more dangerous in terms of cardiac and neurovascular risk. And then this is just really mostly for your reference in terms of how we use these medications and what their typical doses are. In low back pain, there have been many guidelines. The American College of Physicians guidelines is probably the most commonly used. There's a good one from the University of Michigan. The state of Washington has done one with the BRE Collaborative. And almost all of the guidelines for acute back pain list nonsteroidals as the most important, best drug to use. This review is by Roger Chow, and he and the team that looked at these meta-analyses of all the drugs used in low back pain pointed to 3 medication classes that had efficacy in acute low back pain, and those were nonsteroidals, skeletal muscle relaxants, and opioids. They all gave about a 2-point on a 10-point scale reduction in pain in acute back pain, and most people have tried to avoid the use of opioids in acute back pain for obvious reasons, and skeletal muscle relaxants because they've both been of questionable benefit, but also sedating. And so guideline after guideline will point to nonsteroidals as the main agent to use in acute low back pain. Systemic steroids are used a lot in both axial and radicular low back pain, and my experience is they do seem to do something for patients, but if you look at the bulk of the literature, the effects seemed to wash out, and in all of the studies that I looked at, they were describing no benefit from steroids in acute back pain with or without radiculopathy. And then this article came out, and I don't know if you've seen this. Initially I saw in the New York Times and then went to look at the actual articles from Science Translational Medicine, and this came out about 4 months ago. And this was a group of studies that were published out of McGill University in Canada, both animal and human studies, and what they identified was an interesting article because it wasn't exactly a scientific study, but a compilation of those, as I said, that in both humans and animals, the use of non-steroidal agents with acute pain increased the transition from acute to chronic pain. And the ways that they looked at this were several. Animal models of mice given either non-steroidal agents or steroids, they saw a higher transition to chronic pain as compared to when they used gabapentinoids or Tylenol. Those things did not seem to increase the transition to chronic pain. And when mice were given neutrophils, their own neutrophils back again, or neutrophil products, calprotectin is the main neutrophil product, protein product, in acute inflammation, that reversed that chronic pain. And so there is now this belief that needs to be further explored and validated that the use of non-steroidals or steroids in acute musculoskeletal pain may actually predispose to chronic pain. And the conclusions here, I listed just some of those from this group of articles, were that normal healing is actually characterized by intense inflammation, and that inflammation is actually protective and helps resolve that episode. And again, it's these neutrophil products that are inhibited by both nonsteroidals and steroids that seem to be important in resolving chronic pain. So I'm hopeful that we'll start to see, this knowledge translate into new ways to treat acute pain. And what I've been telling my patients is, this pain and acute inflammation is normal. It's probably a good thing, and if you can ride this out, then you should do that. And I don't know that we've gotten to a place yet where we would say you should not use these drugs in acute pain, and obviously it's a balance of trying to treat that intense acute pain that does occur, because these drugs are effective for that, but then the concern about, what's the longer term outcome associated with those. Chronic pain is probably different, and the authors who published those papers in Nature pointed that out as well. This is more of a concern in acute pain, and in chronic pain there are studies showing efficacy, at least in the short term, over a month or so in chronic pain for anti-inflammatory drugs, as well as opioids. And I was surprised, this is a unique finding in this particular review, that topiramate actually seems to have some benefit in chronic low back pain. So I've been using this more, especially with my patients who are overweight, and we're looking for some additional benefit in terms of weight loss. And I think my own conclusions are yet to be made on this, but there is good evidence that that drug may be useful. Again, acetaminophen didn't show any benefit in chronic back pain, and most antidepressants, to my surprise, did not show any effect in chronic back pain, except for duloxetine, which has. And this is one of many articles that are showing kind of the timeline and the magnitude of effect of duloxetine. This is average pain on a 10-point scale of 6 for both the placebo group and the duloxetine group, and 30 to 40% reduction in pain is typically seen, and that takes about 8 to 12 weeks to fully manifest. I was of the impression that these other SNRIs might be equally effective in the treatment of chronic pain, and that hasn't been borne out. And venlafaxine, which is the other most commonly used SNRI, actually has a much higher incidence of hypertension and adverse effects. So duloxetine is the main one in this category that has both evidence and a better safety profile. So it's kind of simplified things for me when my patients are coming in and they want to talk about a medication for chronic back pain. This is the main one in combination with therapy and cognitive behavioral intervention. So the combination of use of duloxetine, if tolerated, cognitive behavioral therapy, and then activation through PT is really what I'm trying to get to with most of my patients with chronic back pain, at least as an initial approach. I think we might be running low on battery on this guy. There we go. Okay, I'm going to move on and talk about opioids. 2022 has been a big year for new publications in regard to opioids. I'll talk about some of these 4 areas. There we go. So we thought we were making progress 5 years ago in overdose deaths related to opioids. And if you look at the light blue line here, the overdose rate, either fatal or non-fatal overdose with prescription opioids, has flattened out starting somewhere around 2010. But I think as most people are aware, the overdose rate related to illicit opioids, and in the last 5 years, especially synthetic illicit opioids, mostly fentanyl, but also other fentanyl derivatives, have been driving overdose deaths to the point that the rate of overdose has continued to rise. And there's been a lot of debate about how much has, physician prescribing of prescription opioids driven this opioid epidemic, and undoubtedly that's played a role, but at the same time, the potency and cost of illicit opioids imported into the United States has increased. So 5 years ago, the price of heroin was about 10% of what it had been 5 years prior to that, and the heroin on the streets was about 10 times as potent as the heroin previously. So it became much more available, and that, as you can see from this graph, became the primary opioid of overdose. And then the synthetic opioids have really taken over, first on the East Coast and now on the West Coast. And you can understand why. A kilogram of fentanyl costs about $5,000 on the illicit market, and the street value of that is about $5 million. And a kilogram of fentanyl is enough to kill about 100,000 people, and it'll fit, into the size of a softball almost. So it's easy to transport, it's inexpensive. Users seem to like it because of the cost and the effect, and it's very hard to dose adequately because it's so potent in microgram quantities. This is more recent data about drug overdose rates just in the last couple years and during the pandemic, whereas we were seeing 70,000 overdose deaths a year, that's now 110,000 or so this year. And so we haven't made the progress that we would have hoped. As a precursor to the new CDC guidelines that came out just a few months ago, the Agency for Health Care Research and Quality did an evidence review for efficacy and harms associated with opioids that was published in February of this year. And unlike previous studies, this one showed small improvements in both pain and function compared to placebo for opioids in long-term use. And that's long-term use less than 6 months, but no real benefit over other drugs used for pain. The evidence for effectiveness and harms using long-acting versus short-acting opioids, different types of opioids, really did not show us any particular advantage. And in fact, what we used to think was that long-acting opioids were more effective because they were not associated with this taking it and feeling better, this sort of reinforcing behavior that time-contingent use of opioid would result in less transition to addiction. That didn't really turn out to be the case, and in fact, the long-acting opioids, starting with OxyContin, were associated with much higher doses. And so, when we're using Percocet with Tylenol component to it, you were really maxed out by the Tylenol component, and when we started to have these potent opioids that were long-acting with no Tylenol associated with it, doses went up significantly to the point where in 2010, the Medicaid population in Washington State, the average morphine equivalent dose was 600 morphine equivalents, which is a lot. And at that time, on the street, it was about $1 per milligram. So folks who were on Medicaid and were often getting $300 or $400 a month in terms of money coming into them for food and housing could, on a daily basis, make $600 if they, chose to sell their opioids. And so all of this was really driving illicit use on the streets. We are all asked to assign risk to our patients. How risky are they in terms of having aberrant use of opioids? And so there are tools that we can use like the opioid risk tool and others. None of those really show any predictive benefit in terms of opioid. We still are asked to use them, but one of the things is HRQ study showed that none of those tools actually is predictive for aberrancy. This slide is the risk of overdose related to dose, and the first studies came out in Seattle at Group Health. Mike Von Korf and his group showed that if you looked at a population compared to 20 morphine equivalents a day, by the time that population reached 100 morphine equivalents a day, their risk of overdose was 10 times as high. And so this has been repeated in many studies, and this was really the basis for the CDC's decision to use these 50 and 90 morphine equivalent thresholds for saying use caution and subsequently don't go over those doses. And so in 2015, they came out with a guideline, and it was really talking about restricting dose above these levels, using caution above these levels. They never really came out and said it's wrong to do this, but that's how it was interpreted. And so we saw a lot of activity reducing opioid doses rather dramatically, or in refusing to go above these doses, and that subsequently was associated with a lot of concern of harm. I think everybody, all of us providers at that time said we've kind of reached a point where we realized this was probably a big mistake to get these patients over all these years habituated to opioids. Let's get them back off, and hopefully they'll get better and this crisis will go away. But these are just a couple of studies that have come out in the last couple of years. And in reading last week, there was another one in JAMA in August. There's another one come out in September. And what these studies are saying is that when you taper patients rapidly off of opioids, they have a higher risk of death in the year or 2 years following their taper than they do if they're maintained on opioids. And this is particularly true if they're tapered quickly, more than 10% per month. So this is really disturbing information. When patients are tapered off of their doses to which they're habituated, they go elsewhere and they find medications from friends or on the street, and their risk of dying is actually higher than if they're maintained. And so that leaves all of us who care for patients who have been on opioids for 10 years in a really kind of a difficult spot. How do we manage these patients? What's the right thing to do? And so this year, CDC came out with new guidelines, and I think we'll talk about some of the things that were a little bit different from the previous guideline, but I think the main thing that was different was to tell practitioners that these previous thresholds of 50 and 90, these were only sort of guidelines to think about, and that the risk does increase, but they were particularly informed by patient advocacy groups to say, people are misinterpreting these guidelines and patients are being harmed because of the rigidity with which these were interpreted. But these are of the 12 recommendations in the current guideline, some of the highlights. As always, use other drugs first. Establish goals for pain and function before you start, and if early on those things are not being met, then quickly take your patients back off of opioids. Don't start with long-acting opioids because that's associated with a higher degree of overdose death, so short-acting opioids initially. Short durations, like a couple of days for opioids. I think when I started practicing, it was typical, 30 Percocet and maybe some Flexeril for acute low back pain. These days, it's maybe you should prescribe 1 or 2 days worth of opioid, if at all, and then try not to continue that. Use the lowest effective dose. The guideline also had a lot of emphasis on co-prescription with benzodiazepines in particular, and the concern about avoiding that. 10 years ago, I would say 40% of patients who were on chronic opioid therapy for more than 3 months were also on benzodiazepines, which is amazing. I think it's more like 10% now, and I think our profession has done a good job in reducing benzodiazepine prescription, especially when co-prescribed with opioids. And then the CDC would say identify and treat opioid use disorder, and when you do start these patients on opioids, really frequent follow-up is very important. So the BRE Collaborative in Washington State, which is a public-private partnership between payer groups and regulatory groups and provider groups, has addressed this chronic opioid therapy situation. What do we do with these patients who are, we might call them legacy patients, but they've been on opioids, often high-dose opioids, for many years. We're all uncomfortable about this. We know that this is a high-risk situation, so what should we do with this group? These very thoughtful group of experts came together, and they basically said, if patients are stable and they're doing okay, if the benefits seem to outweigh the risks associated with this therapy, then maintain those patients and monitor and keep them safe. So check their urine toxicology screens, make sure that they're not using non-prescribed opioids, and try to minimize co-prescription, but do this in a safe way. It's very hard to say when the benefits are outweighing the risks. I think all of us, as we see our patients, we don't honestly know, but I think in usual practice, unless something bad is happening, unless you're detecting some aberrancies that are repeating themselves, then it's okay to maintain and monitor patients. And in our group, we're doing this. We follow a lot of patients who've been on opioids for 15 or 20 years, and we're trying to very, very slowly reduce their dose over time. When people do run into trouble, whether that's clearly opioid use disorder or maybe more commonly early refills, the medicine's not working for me anymore, I seem to be developing more pain than I had before, then tapering is a reasonable strategy. And the BRE Collaborative recommended these 2019 guidelines by HHS, which talk about the rate of taper, supportive things that you can do in association with taper to make it more successful. So we can certainly try that. The rate of taper really depends on how urgent is the situation. If somebody looks like they're at risk of having an overdose because they're really out of control, then a faster taper or other alternative approaches are indicated. But in general, this taper should be slow, and that's probably less than 10% per month. And then the third pathway, if taper is not working, are medications for opioid use disorder, and that for us is primarily buprenorphine. This year, the BRE Collaborative came out with guidelines of how to treat older patients who are on chronic opioid therapy. So assuming you were maintaining and monitoring and people were doing okay and not having a lot of aberrancy, they still get older, and by the time people are reaching their 60s, they're having more problems with metabolizing and handling these kinds of medications. And the reasons for this are complex. Some of those are metabolic reasons, fluctuating renal function and change in pharmacodynamics and kinetics in older people, but also increased comorbidity, and people tend to accumulate lots of medications as they see doctors over time, and even social isolation where they're not getting feedback from people that they're with that they're not doing so well on these medications. And so while prescription opioid overdoses are going down for almost all groups, they actually are going up for people over 65. And in the HRQ review, the rates of overdose were highest in older patients in Washington State and in Oregon State. This guideline, which I'd encourage you to read, has these focus areas about acute prescribing, intermittent prescribing, how to use non-opioids, how to use non-drug approaches, and how to taper and de-prescribe. One of the biggest, I think, easy to implement areas was co-prescription, and see if I can get this thing to move. Co-prescription with other anticholinergic agents, tricyclic agents, muscle relaxants, and gabapentinoids. So just reducing those other medications without even reducing the opioids does increase the safety profile. And there have been a number of publications recently talking about the risk of gabapentinoids, both Lyrica or pregabalin and gabapentin, in association with opioids, causing increase in respiratory suppression. So some of the pearls from this approach to older patients would include starting at about 25 to 50% of the usual dose if you're going to use an opioid, avoiding complex regimens, especially avoiding morphine, which because of variability in renal function tends to be more dangerous in older people because of the buildup of toxic metabolites, and look for opportunities to reduce co-prescribed agents. And then I don't know a lot about the Medicare medication therapy management program, but I think those involved in certain Medicare programs have this benefit where they can meet with a pharmacist and just go through yearly their medication regimen and make changes to that as recommended. They did refer quite a lot to the Beers criteria. A lot of their work was taken from that. And there was a lot of emphasis on exercise strategies like Tai Chi, which not only have pain-relieving benefits, but benefits in terms of fitness and fall reduction. So I want to say a few words about buprenorphine, which I think is a drug that many of us are getting more comfortable with, but many of us are still fairly uncomfortable with. So buprenorphine was first developed in 1970s in Europe as a pain medication. It's a partial mu agonist. It binds to the mu receptor very strongly, but it only partially activates that receptor, and so that's why it's called a partial mu agonist. We worry about this because if you give somebody who's on typical opioids buprenorphine and it so avidly binds the mu receptor that it kicks the other drugs off, then it can precipitate withdrawal, and that's not a good thing, and that withdrawal then it becomes very hard to treat in that setting. So there are these protocols where you have people go into mild withdrawal before starting buprenorphine, or you can start buprenorphine at very low and slowly incremental doses and avoid that precipitated withdrawal. The primary form used for addiction is a combination of buprenorphine and naloxone, Suboxone, which previously required a special license, but starting a couple of years ago, if you treat up to 30 patients, even those with opioid use disorder with buprenorphine, you don't need that special X waiver, and anytime you're using it for pain rather than for opioid use disorder, you don't need a special license. And this is just a cartoon of how this drug works. The little gold spheres there are the buprenorphine, which bind, and if binding the mu receptor can block other typical opioids from binding, or if given while those are bound to the receptor can actually kick the typical agonist off of the receptor. And there are a couple of things here that are worth getting into the detail of. The main point of this slide here is to point out the binding avidity of different agents. So buprenorphine, the middle box here, is talking about what we call the inhibition constant. And buprenorphine, by having a very low inhibition constant, is the most avidly binding agent to the mu receptor. Hydromorphone or Dilaudid binds fairly avidly as well. So in patients who are, for example, in the hospital on buprenorphine and you need to treat them for incident pain like a fracture or surgery, hydromorphone is the best drug to use if you're not going to discontinue the buprenorphine because it'll bind the receptor pretty well. And then there's a big jump to fentanyl, methadone, oxycodone, and hydrocodone, which much less avidly bind the receptor. So they're not going to do very much in the setting of chronic buprenorphine. And then this talks about a couple things that are important to know. The graph on the right is the elimination half-life, essentially, of buprenorphine. And it is a very long-acting agent, and it, when it's used for addiction, can be given once a day. People don't get a real drop in their blood level, and so their craving for opioids is reduced over the course of a couple of days. However, the analgesic half-life of buprenorphine is much shorter, and if we're going to use it for pain, then we typically will use it on a TID or a QID basis because the analgesic half-life is about 6 hours. The graph on the left is talking about the receptor occupancy at various doses of buprenorphine. It's a little bit hard to read, but the point is that by the time you get to between 16 and 24 milligrams of buprenorphine, you've got almost all the body's mu receptors occupied, and so we tend to use, now it's changed automatically. We tend to use about 24 milligrams of buprenorphine to maximize pain effects. As you get higher than that, it's well enough tolerated and it doesn't cause additional respiratory suppression, for example. But some studies have shown that higher than 24 milligrams start to increase the dysphoric effect of buprenorphine, so people start to feel worse when they get on higher doses. This slide is just one example of studies that have been done to assess the efficacy of pain reduction in buprenorphine. So in the United States, it's been used mostly for opioid use disorder, but there is a good pain effect. And this is one study that looked at patients who'd been on pretty high doses of opioids over a long period of time, and they'd either lost their effectiveness or for other reasons, patients were transitioned to buprenorphine. And they tended to get both improvements in safety and also improvements in pain. So in this particular study, on a 10-point scale, people's pain went down by about 2 to 3 points when transitioned from typical opioids to buprenorphine. So we're using a lot for pain, especially in people who've ended up having some problems with the typical opioids, and patients will often interpret that we're now treating addiction instead of pain. But I feel confident in telling them that actually this is a pretty good pain medication too, and I think it may actually help you to make this transition. And then just kind of a summary of our current approach to trying to mitigate the opioid crisis. One is try not to transition from acute prescribing to chronic prescribing. It's easy to do, and once patients have been on opioids for 6 months, they have a 60 to 70% chance of remaining on them in 5 years. So if you're going to make a change, you want to do that early and not create a new chronic opioid therapy patient when it's not really necessary. When patients are on chronic opioids, and we see plenty of this, of course, manage them carefully, reduce polypharmacy, try to very slowly reduce dose over time if that's well tolerated, and especially don't abandon patients because they have aberrancies or they've done things that are outside of the prescription. Those people, if we cut them off, and frankly, many of these patients are in this situation in part because of prescribers, we owe it to them to continue to treat them and to get them into proper care. In most cases, that's using buprenorphine if that's successful for them, but don't just let them out of care if possible. They've got a problem that's a neurological problem now related to opioids, and then recognize and treat opioid use disorder. And it's rarely very clear, that this is good chronic opioid therapy, this is addiction. It's all mixed together. We can't often tell, when our patients are having elements of opioid use disorder along with, their prescribed regular use of opioids. So we just take a pragmatic approach and say, if this isn't working or problems are starting to occur, we're going to change directions, probably change you to buprenorphine, start to get more cognitive behavioral therapy and supportive therapy for you, and keep you in care. Thank you. Thanks.